This is what we all wish you, success. But success is not easy. Success requires hard work, just like ants. And if you find it difficult, the answer is time management. Go and study time management. The drug of choice is time management. We need to make our ideas bigger and bigger and bigger until they shine. How do they shine? They shine by reading books. Doctors read books. It is useless for somebody carrying his brain without any light. It's useless. The bulb is not shining. So you cannot be a doctor with an off light bulb. You cannot go to the hospital with your brain full of, I don't know, I have no idea. You cannot treat people like this. You need shiny ideas. Few shiny ideas here and there are not enough. So we need to work on our brains, right? Now, open your mouth opposite the mirror, and this is what you see. This is a normal oropharynx. Why it's a normal? Because you can see that the color of the uvula, the soft palate, posterior wall of the oropharynx, the tongue, all colors are almost the same. No congestion. So this is a normal oropharynx. This is the opposite. You can see that there are signs of inflammation, dilated blood vessels, and redness. The color here is quite different from the soft palate, uvula, and the tongue. This is pharyngitis. You're going to see lots of these cases of pharyngitis. Here you can see that the posterior wall of the oropharynx, because of repeated infections, you can see that these lymphoid follicles are enlarged. This tells me that the oropharynx, or the wall of the pharynx, has lymphoid follicles. This is a bad case of inflammation, tonsillitis, uveitis. The tongue is all right, but the tonsils are very large, and you can see the wall of the oropharynx is fiery red. Now, this is the oropharynx. Now we want to go behind the tongue. This is the tongue. When you go behind it, and you need an endoscope, you cannot see this with a tongue depressor. You need an endoscope. You know what the structure is. This is the epiglottis, a valve protecting the opening of the larynx. And there is a medial fold called glossoepiglottic fold, and there's a lateral fold here called lateral glossoepiglottic, and there's another one, and there is a depression, a fossa called vallecula. Now, if food is stuck here, there is no problem. You drink water and whatever is stuck here, it will go down. If you go deeper, that's the vallecula. This is the median glossoepiglottic fold, lateral glossoepiglottic fold, and this is the other lateral epiglottic fold. Now the endoscope here is showing the vocal cords. The problem is here. There's a depression called piriform fossa. And the way to the esophagus is behind this cricoid cartilage. Now, anesthetists, they have to learn this, that if they want to introduce a tube, okay, they should go through the two vocal cords. They shouldn't do it blindly. If they go this way, this is the way to the esophagus. This is the piriform fossa. This image from a cadaver, and this is the uvula, this is the soft palate. Here the pharynx is opened posteriorly. This is the uvula. This is the soft palate. This is the tongue. And this is the epiglottis going down, right? And the piriform fossa is going to be here this way. So this is the soft palate, this is the tongue, this is the epiglottis, the median glossoepiglottic fold, epiglottic vallecula, lateral glossoepiglottic fold. This is a diagram. Again, soft palate, tongue, epiglottis, and this is the piriform fossa. Where is the piriform fossa? There is a membrane called ari-epiglottic membrane between arytenoid cartilage and epiglottis. And this is the wall of the pharynx, and the fossa lies here. The problem of this fossa is that if anything gets stuck here, we have to go and pick it up. Eating food or drinking water will not pull it down. This is the piriform fossa. Which part of the pharynx is this? Respiratory part. This is the soft palate. This is the tongue. This is oropharynx. This is the epiglottis. This is the vocal cord. This is laryngopharynx. This is the esophagus. Here the esophagus is marked with green color. Here is a foreign body in Piriform Posture. It's very distressing, and the patient coughs, no benefit. Drinks water, no response. Eats something, nothing is happening. So this requires endoscopy and going down to the piriform fossa and picking it up. This is also a posterior view of the pharynx. This is the superior pharyngeal constrictor. You see, the pharynx is described as fibromuscular. Why the word fibro? Because the upper part, which makes the nasopharynx, is a respiratory passage, and it should not collapse. Therefore, it is made of fibrous tissue. You go lower down, it's going to be muscular because it's made of constrictors, and when you say constrictors, they contract and obliterate the lumen to push the bolus down. So this is the superior pharyngeal constrictor, this is the middle pharyngeal constrictor, and this is the inferior pharyngeal constrictor. This is the cricopharyngeal part of the inferior constrictor. Now, why does it have a special name? It's the lowest part of the inferior constrictor, and the fibers are circular, and it marks the beginning of the esophagus. The esophagus has 3 constrictions, normal constrictions. This is constriction number 1, the very beginning of the esophagus. The pharynx is made of 2 sets of muscles. The constrictors, which are 3 cones of muscles, one on top of each other, and the fibers are either horizontal or oblique. And there are 2 muscles that are vertical. You see, when you want to put something in a case, the best way is what? Is hold this box, for example. The same way as you put it down, you pull the case up so that the box can come down very easily. So you need vertical muscles. And the vertical muscle number 1 is Stylopharyngeus. It's coming from styloid process. The other one is Palatopharyngeus, coming from the soft palate. So when you swallow something, the constrictors will squeeze the bolus, and these 2 vertical muscles will pull up the pharynx so that the bolus goes down easily. This is another image of posterior view of the pharynx. The 3 constrictors, as they come from different parts anteriorly, they meet posteriorly in a line called the median raphe. This is the insertion of the 3 constrictors. This is the superior constrictor that has the fibrous part. This is the middle constrictor, and this is the inferior constrictor. This is a diagram. Now, the diagram is drawn after studying the real thing. We have seen the real thing, and the diagram can help sometimes. This is the raphe, and this is the superior constrictor, and you can see that this is the fibrous part of the superior constrictor. It is attached at one point at the base of the skull. Occipital bone has a tubercle called pharyngeal tubercle. So the whole pharynx is attached to the base of the skull by a single point, which is the pharyngeal tubercle on the occipital bone. This is the fibrous part, because this is the nasopharynx, and we don't like the nasopharynx to collapse. This is the middle constrictor, and this is the inferior constrictor, and this is the cricopharyngeus, which is circular, marking the beginning of the esophagus. This is a lateral view showing the three constrictors, and this is a posterior view demonstrating the visible Stylopharyngeus muscle. Piriform fossa, again, it's important. Piriform fossa is important. This is the nasopharynx, this is the oropharynx, and this is laryngopharynx, and this is the beginning of the esophagus. Again, let's orient ourselves here. This is the soft palate, uvula, tongue. This is the epiglottis. When you swallow something, the epiglottis goes down and closes the inlet of the larynx, and the food should come down to the laryngopharynx, down to the esophagus. Sometimes things go to piriform fossa. You may receive a patient saying, I have something stuck in my neck, and they cough, no response. They drink water, no response. They eat large bursts of bread, no response. And you ask them, what did you have for lunch? He or she may say, I had fish. You take an X-ray, a lateral X-ray. You don't take a PAP X-ray, because if there's anything, it's going to be masked by the shadow of the vertebra. The first thing you see is that this is the wall of the pharynx, and the wall of the pharynx has a fascia on the outside, which is stuck with the prevertebral fascia. So this line of air is not normal. And you come down here, and you can see this line here. Is there any bony structure, normal bone structure lying this way and this side? The answer is no. Now, this is opposite what? Which vertebra is this? C1, C2, C3, C4, C5, C6. So, is this in the trachea or in the esophagus or in the pharynx? Therefore, the piece of information that tells you that the esophagus starts at C6. Because if this is in the esophagus, then you have to call an endoscopist and take him to a special room take this bone. If this is in the trachea, you call another person with another equipment. So this is a fish bone in the Piriform Posture. This is the oropharynx. This is a diagram showing you the three parts of the pharynx. Now, we will go into the esophagus. The first esophageal constriction is the lower end of the lower or inferior constrictor. It's usually closed. Okay. When you pass the endoscope through it, you will go into the esophagus. This is the normal image of a normal esophagus. You go through the esophagus. Going through the esophagus requires very good knowledge of the course of the esophagus. In this image, the esophagus is marked green, and it tells me that the upper part of the esophagus is posterior to the trachea, and it is posterior to the aortic arch, because this is the aorta. This is the descending aorta, and it is in the mediastinum. If you push the scope without seeing the way you are pushing it, and you perforate the esophagus, that is a big problem, because mediastinitis is very serious disease. It's a very serious problem. And the esophagus comes down and turns slightly towards the left to pierce the diaphragm, and has an intra-abdominal portion which is going to join the stomach. We used to hate the esophagus very much. Do you know why? Because it's in the posterior mediastinum, because it is very deep, because we cannot put our hand on it. We cannot examine the esophagus. The esophagus is a deep structure. We don't know what's happening here. But when the endoscope came in, it solved part of the problem. And later on, when the CT scans and the MRIs came in, we used to have no problem with the esophagus. This is the sternum, manubrium and xiphoid process, and this is the heart. The most posterior part of the heart is the left atrium, and this is the aorta, and this is the esophagus. So if there's any problem with the esophagus, it can be diagnosed easily. This is the liver and this is the diaphragm. So this is a normal esophagus. Now, when we resort to diagrams, demonstrate the relations. The esophagus has three parts. Part of the esophagus is in the neck. Most part is in the thorax, and a small part is in the abdomen. So this is the first part, just inferior to the lower part of the inferior constrictor, behind the trachea. comes down, the trachea ends, and the esophagus goes posterior to the heart. First of all, posterior to the great vessels. Then posterior to the left atrium, approaches the diaphragm and pierces the diaphragm to become abdominal organ. In this image, we have to take care when we push an endoscope into the esophagus, because the descending aorta is just posterior to it. Sometimes the thoracic duct is running on the right. If you injure the thoracic duct, the whole thoracic cavity will be filled with lymph, and it will depress the respiration. This is an image of what is called barium swallow. You give the patient a glass of a dye, which is radio-opaque, and ask the patient to swallow it. But you have to take the images very quickly, because the barium will come down to the stomach very quickly, and you have to take an oblique view. Here's the thoracic part, and then the esophagus goes down behind the heart, and this is the impression of different structures of the heart, and then it comes down, this is the diaphragm, and this is the stomach full of barium. It shows us what's happening in the esophagus, but not very good information like the endoscope. But it tells us something. Okay, so it goes posterior to the heart, pierces the diaphragm, and becomes abdominal. This is an esophagus which is so much dilated and looks very bad. It looks very bad. So there is bad pathology in the esophagus. This is a view of posterior abdominal wall and the diaphragm. This is the right crus of the diaphragm, part of the vertebral origin of the diaphragm, that goes up towards the left and then curves around and has an opening. The esophagus is going to pass through this opening at the level of T10. Now, if you look at this CT scan image, and this is the esophagus, these are the great vessels, and this is trachea full of air, and the esophagus is posterior to trachea. Again, these are great vessels, and this is a normal, nice looking esophagus. Nice looking esophagus, but in this image, it's not nice. Thick wall, tiny lumen. It is so obvious that this is not normal. barium swallow with a normal esophagus, here is something bad. The esophagus is dilated and constricted lower down. The esophagus has went into spasm. For some reason, this disease is called achalasia. Dilated esophagus, tapering abruptly, and this is esophageal achalasia. So you can see the difference between a normal barium swallow and you know what the patient is going to say to you here? Food is getting stuck here behind the sternum. Okay? And this person is going to vomit undigested food. This is a lateral view of achalasia. People call this rat tail appearance, as if this is the rat and this is the tail of the rat. If we look at this barium swallow, we can see it's different. There are these fillings. And it is dilated as well. So what's the problem here? Sabaya, be quiet please. Now you know that we have a portal circulation and we have a systemic circulation. Is there any connection between portal circulation and systemic circulation? The answer is yes. In 4 places. In 4 places. Lower end of esophagus. Yeah, Basha. Small food. Nowhere. Lower end of esophagus. Wide. Around the umbilicus. Wide. In the rectum. Wide. Posterior abdominal wall. So if the liver has a problem like cirrhosis, and the fibrosis of cirrhosis is going to press on the veins, now the blood as a liquid builds back pressure, and this back pressure will find a way to get out. So this back pressure will force blood to go to the systemic circulation. One, you can see these veins, especially the left gastric vein, is tortuous, building back pressure, and the lower end of the esophagus drains into the left gastric vein. So these veins are going to dilate. And when veins dilate, they become tortuous and dilated. And they create a big problem. This is an endoscope of the esophagus where you can see the veins are dilated. Now, you know the wall of the veins is thin, and if they rupture, they bleed. They bleed so severely. So severely. And you have to, first step, you have to give blood. many pints of blood. Let's go through this mind map. Blood. Okay, it's hard to treat such. An overview case. It is the largest salivary gland and it is lobulated. Minor case of esophageal. Is this important to say that it is lobulated? Lower end of the esophagus drains to the, if it gets smooth, gastric then part of either distended or sensory problem. Now, shape, look at this pyramidal. Endoscopic image, you can see that a pyramid has an apex and a base. Are normal area. The apex is inferior and there are red here to the margin of the mandible there. Why do I have this bump here? Danger. We have just folds. These folds are folds of normal. Superior is the base, so the connection between the superior and the extended auditory meatus. Now, almost when it is, so whenever the superior to external auditory meatus, at the beginning down, the patient will come and say what? And food comes out into open my mouth. I have pain in the ear. Is lined with stratified squamous epithelium without opening the mouth, which is not pain in the ear. You examine, tolerate, send the patient to the ear. The patient feels pain and thus examines the ear and says to the mouth, there is no problem. This is called reflux. There is no problem. We'll go and examine. The reason is something we will know and go and examine the piriform gland. Now, it can be mild capsules and it is not capsule. If it continues capsules, on capsule, because it lost extra one from the deep investing fascia of the neck, then it becomes a big problem. This piece of information was the basis of partitis or mumps, fibrosis, and it's painful. Is probably narrowing off. Children are usually affected, and then they try all night a dilemma at the beginning. Now, here's a diagram going to cry the first night, the second night, and the mother entering the mother stomach through the diaphragm, the kid to you. These are examinations of the dura of the diaphragm. Do physical examination. Examine keeps this. It is very painful. Lower end of the esophagus closed, and it is only opened by peristalsis. Now, surfaces, the superior surface has diaphragm, right across the diaphragm, posterior to the TM joint, and this fat goes behind. This fat helps forming the valvular process, and sometimes the gland has an accessory valve in the wall of the esophagus. The answer is no. The valvular action is created by the right crus, the fat, and there's the angle between the esophagus process and the medial to the cerebral muscle, and the stomach gets full process, and the distended extension. This part is going to be pushed that way. We have talked about the lower end of the esophagus. Structure is passing through the gland, facial nerve. Divides the gland into superficial. Again, a baryon, then swollen nodes, where you can see artery, that intramandibular vein. Esophagus is so much dilated, and nerve supply, esophageal junction, is above the diaphragm. Salivary glands, they need sympathetic diaphragm here, and part of the stomach is sympathetic with going up into the thick secretions. It's called parasympathetic, will produce watery secretions. Again, you take an X-ray when you see the exam. See that this is the heart. You have got these posterior to the heart. There is a shadow of structure Why should air players always spit? ليش لاعبين الكرة بيبزقوا دايما going up into the thorax? And the hiatus they are concentrating very much. Sympathetic axis is high, and salivary secretion. You can see that, and parts of the stomach have thick secretions in your mouth. So they do what? They spit. A normal person who spits, it's different types of hiatus hernia, right? It's antisocial. But a football is allowed to do that.
This is the esophagus. This is the lower end of the esophagus.
Right?
The esophagus is lying here to stratified squamous, non-keratinized epithelium. The stomach is lying with glandular, simple columnar forms gland.
Now we have talked about the transition parts of the tongue,
lower end of the esophagus,
the mucous membrane.
Gradual.
We are not really concerned about taste. Nobody is going to come to us saying, I cannot feel
the
salt.
lining of the esophagus, and you can see there is a sudden change.
40, 50 years in medicine and never received a complaint saying, look, I cannot feel salt. Right? So it's not really bad, not important thing about these are the intrinsic muscles and the extrinsic muscles. And deviated tongue, why you sound stupid? Why do we hate the esophagus? Do you know average life of Thank you very much. You go to the books and look for survival implications of cancer or Now, why is that? Why is that? Cancer spread either by veins or lymphatics. So if we go to the lymph drainage of the esophagus. It is extensive and it is longitudinally continuous in the submucosal lymphatic system. Continuous submucosal from upper part to lower part. There are two types of lymphatic vessels. Plexus of large vessels and the mucous membrane. Okay, and there's a second plexus, which is finer one in the muscular cord. So that's the internal arrangement of the lymphatics of the esophagus. Vessels from the cervical part go to the deep cervical lymph nodes. And even if the tumor is lower down, okay, and you go to the fact that lymphatics are longitudinally continuous, and the cancer cells أجرها تروح لفوق وعطتنا deep cervical lymph node. Now when doctors see deep cervical lymph nodes, they say, okay, the problem is in the structures of head and neck. So they go in a different direction away from the esophagus. If they remember this fact, they will say, okay, I will investigate the throat. Now the throat is not an easy structure to investigate because it is dark and has little spaces. So you go with an endoscope, you put the light here and there, and you find nothing. But usually people forget the esophagus, right? So this is a misleading part. Thoracic part of the esophagus, lymphatics go to the posterior mediastinal lymph node, and it is usually missed with cancer of the lung. The abdominal part, they will go to the left gastric node. The problem with the left gastric node is that you cannot feel them, and they get larger and larger without being aware of. So the case is missed. The case is missed. Some vessels, and here is the most dangerous thing, some vessels, they end up in the thoracic duct directly. That means that cancer of the esophagus becomes systemic from the beginning, because the thoracic duct goes and empties into the subclavian vein, and the cancer cells will spread. Therefore, spreading of cancer of the esophagus so easy and so easily missed. Deep cervical lymph node, people don't think of the esophagus because they don't know this fact. Posterior mediastinal, okay, they take chest X-ray, CT scan of the chest, vertebra, nothing is found. Said, okay, we will wait for 3 months and repeat it again while the cancer is flourishing. And the most dangerous thing is that some lymphatics empty into thoracic duct. That's why we hate the esophagus. And people don't have long survival. There is another point. Now, we have seen the direct relation between the esophagus and the heart. The heart is in front of the esophagus, and both of them are supplied by the vagus nerve. And the patient comes and says, I have retrosternal pain. Right? If you are not aware of this connection, okay, you have retrosternal pain, you have angina. You have a problem in the blood supply of the heart. You do all investigations and say, okay, I will give you symptomatic treatment, while the pain is, pathology is in the esophagus. You see, there is a very basic knowledge that must be learned. Cannot ignore it. We have to consider it. And this is what we have to consider in nerve supply of the esophagus. Thank you very much.